Good afternoon, and thank you everyone for being with us today for our second seminar of this semester. We're very happy today to be hosting Dr. Nansi Boghossian, who is an associate professor in the Department of Epidemiology and Biostatistics in the Arnold School of Public Health at the University of South Carolina. Dr. Boghossian's research focuses on maternal morbidity and outcomes of extremely preterm infants, integrating social determinants of health, pregnancy complications, and health policy with emphasis on the postpartum period, an often overlooked but critical phase of care. Dr. Boghossian leads two NIH R01 grants on hospital quality, Medicaid expansion and extension, and racial/ethnic disparities in maternal outcomes, alongside additional grants focused on postpartum health. She also leverages Vermont-Oxford network data to examine disparities in care practices and outcomes for extremely preterm infants. Using population-based and translational approaches, her work aims to reduce preventable maternal complications while improving long-term outcomes for mothers and infants. And I would like to mention also that Nansi is a graduate of FHS and of the PhD department, and we also shared an office as research assistants, both of us, back in the old days. And so I'm very happy to have her today, a presenter in our seminar series.
Thank you, Dr. Ghena, for this introduction, and I'm glad to be here. It's been a very, very long time, but it's great to see again very familiar faces and be back to AUB. It's always very refreshing, and I'm visiting. Yes, I'm visiting for 1 week. So I have a family I've left behind, so I need to go back to my kids at some point. Freedom for 1 week. Okay, so I'm going to start with a little about me. I was born in Lebanon, in Anjar, actually. I'm a Lebanese of Armenian background. I graduated from the AUB with my master's degree in public health, and then I did my practicum first at the NCPNN, National Collaborative Perinatal Neonatal Network at AUB-MC, and then stayed there and worked for a year. After that, I became really passionate about maternal and child health and felt that I needed to further my education. And so I moved to the US and I got my PhD in perinatal epidemiology from the University of Iowa. Then I did my postdoc at the National Institute of Child Health and Human Development in their Department of Population Health Research. And following that, I've been at the University of South Carolina, started as an assistant and now associate, and going to full, hopefully, this summer. So my research focuses on complications of extremely preterm infants and also on maternal mortality and severe maternal morbidity. We'll define these terms shortly. And within these two research foci, my research aims to sort of have a translational lens, evaluating policies that's in the US context, and also designing interventions to improve maternal and newborn outcomes. So just a brief outline of what I will cover today. First, I will talk about the landscape of maternal health, focusing on key trends and disparities. Then I'll talk about the importance of the postpartum period. That's an overlooked period usually. From there, I'll mention a bit about high-risk populations, focusing on social and clinical risk factors, get into a policy deep dive on Medicaid expansion and Medicaid extension, and abortion restrictions and policies. And then I'll talk about two projects we're working on, blood pressure monitoring in the postpartum period and neonatal excellence in supporting transitions. And then we'll close it with having a sort of a discussion, questions, and potential areas for future collaboration. So first, to provide a bit of context about maternal health in the US. The US continues to have the highest maternal mortality rate, with the rate for Black women by far being the highest of any group among high-income countries. And so this is the US Black rate over here. This is 49.5 deaths per 100,000 live births, and the US rate is 22.3. And as you can see, it lags behind all of the high-income countries. And this rate hasn't changed between 2022 and 2023. If anything, the rate for Black moms for death has increased. There was a slight decrease for white moms. And so in 2022, Black moms were 2.6 times at a higher risk than white moms. And in 2023, at 3.5 times of death than white mothers. But there are also major disparities across states. And so you can see over here, the crude pregnancy-related mortality rate per 100,000 live births. And the southern region is the region that has some of the highest rates of maternal pregnancy-related deaths, with lower rates on the West Coast. And there's a lot of potential explanations for that, policies being one of them. We talk a lot about racism and about Black individuals being more likely to reside in the South compared to other areas. Transitioning to the importance of the postpartum period, some of you might be aware of this, but in the U.S. we have what's known as the Maternal Mortality Review Committees. So not all states, but the majority of states have review committees that review each death that happens among pregnant moms during pregnancy, during delivery, or in the postpartum period. And based on that, they decide on whether a cause of death is preventable. And the hope to do that is to try to improve care and to come up with different interventions or policies to see whether we can reduce maternal death rate based again on the causes of death. And so this data is based on 36 maternal mortality review committees from 36 US states. And they show that the majority of these deaths really occur in the postpartum period. So specifically, 65% of maternal deaths occur in the postpartum. And again, this is usually an overlooked phase. We provide care to the mom during pregnancy. She delivers. Mom is okay, baby's okay, everyone goes home, and that's the end of the story. But more and more, we've been seeing that a lot of these adverse outcomes occur in the postpartum period, and that's usually an overlooked period. The story is similar in the state where I live, in South Carolina. South Carolina ranks among the top 8 states in maternal mortality. And again, the majority of these deaths occur postpartum. Around 67% occur in the postpartum period. And to be specific, 33.3% occur between 43 days and 1 year postpartum. And these are the leading causes of pregnancy-related deaths in South Carolina. They are similar overall in the US, but and specifically in between 2018 and 2020, mental health conditions and substance use disorders was the top cause of maternal mortality, followed by thrombotic embolism, cardiomyopathy, infections, and hemorrhage, almost 12%, and then cardiovascular conditions. Right, yeah. This doesn't include homicide and accidents, but it does include suicide. Say that again. Depression, yes. And the majority of these pregnancy-related deaths are preventable. And so for 2020, almost 94.5% are preventable. And so there is a lot of ways that we can intervene in order to prevent these deaths. The percentages have changed over time, partly because mental health conditions are largely preventable. And so in 2020, again, mental health conditions was the top cause, and substance use disorder, compared to earlier years where it might have been second or third cause. But again, the majority of these deaths are preventable. And almost 75% of these deaths that occur are among Medicaid. So Medicaid is a type of insurance that pays for low-income individuals. And so if you qualify based on a certain federal poverty level, below that threshold, you're eligible to have insurance, to have Medicaid. Medicaid coverage differs by state. And so you might have some states that cover, we'll talk a bit later, that cover sort of your insurance irrespective of your pregnancy status. So there would be, for states that have expanded Medicaid, individuals can have insurance coverage all throughout based on their income. But for certain states that have not expanded Medicaid, pregnancy is an eligibility factor. So if they get pregnant, they get Medicaid. But then after delivery, 60 days after the delivery, they lose insurance coverage. And so they become uninsured again. Right. So anyone who's on Medicaid, so either on Obamacare due to their certain threshold of income, or on pregnancy Medicaid. So anyone, this captures anyone on Medicaid, whether it's due to Obamacare Medicaid or whether due to their pregnancy status. And I'll talk a bit more about this. And so again, the majority of these deaths are low-income moms who are dying. But maternal mortality is really the tip of the iceberg. There's also what's known as severe maternal morbidity. And this is based on 20 indicators that I'll mention over here. So this includes, it's based on the CDC definition. It includes things like acute myocardial infarction, aneurysm, acute renal failure, hysterectomy, shock, sepsis, acute heart failure. So all of these qualify to be considered a severe maternal morbidity or an SMM. So it's basically sort of like a near miss. It's a severe adverse outcome that affects the mom on the short or on the long term. And so severe maternal morbidity is 50 times more common than maternal mortality. So again, it's really important to monitor SMM. But traditionally, SMM has really been examined during the delivery hospitalization. Studies have not explored SMM during the postpartum period or during pregnancy. And so what we did is using data from several states. I think we have like 6 states over here. The data that we use is birth and fetal death certificate data. So every baby born in the US, they get a birth certificate, and they have certain indicators on it, certain social demographic factors like race, education, type of insurance. This data is linked to hospital discharge data for the mom and the baby. And so the hospital discharge data is data that is based on ICD codes. These are used for billing purposes. So these data are linked for 6 states. We're getting more and more states. It's a lot of work to get data from these states. But we found that if you account for SMM during the antenatal and the postpartum period, you basically add an additional 50% of SMM cases. And so cases added during antenatal or 1 to 42 days postpartum, that's 30%. And there's an additional 19% of SMM cases that you can miss if you don't go back, if you don't go beyond 43 days postpartum. So again, high burden if you account for the postpartum period. And this is sort of the timing of postpartum SMM in days after delivery. The blue, the time since delivery is here on the x-axis, and here on the top you have the SMM. And so the light blue represents the SMM cases that occur within the 42 days postpartum, and the dark blue are after 42 days postpartum. So again, they're still occurring beyond 42 days postpartum, and this is up to 365 days postpartum. So moving on from the importance of the postpartum period to talk about high-risk populations. So one of the risk factors that we always examine is race and ethnicity. And so over here, if you look at the top figure here is, again, SMM during pregnancy. The middle figure is SMM during the delivery hospitalization, and the bottom is SMM during the postpartum period. And these different colors are based on race. So you have white, Black, Hispanic, Asian, and American Indian. And what we see is that during the delivery hospitalization, the racial disparity between Black compared to white, Blacks, the SMM is 1.9 times more common among Black compared to white moms. But if you account for the postpartum period, the disparity is bigger, it's wider. So it becomes 2.5 times more common among Black than white mothers. And this is sort of a similar story, but here we control for education, and education doesn't really mitigate those differences between Black and white moms. Again, similar story by insurance type. During the birth hospitalization, Black compared to white moms, it's 1.2 times for SMM. If you look at the postpartum period, it's 1.8 times. And this is another indicator. It's called the MVI, Maternal Vulnerability Index. This is a recent index that has been developed by a group out of Harvard. And before, the indices that used to be used are related to sort of the whole population within a zip code. But this group developed an index that's specific to women of reproductive age. And so here you have sort of the sub-themes and the indicators that they used. It's sort of things like minimum distance to nearest abortion clinic, ratio of obstetrician providers per woman. So all of these indicators is what encompasses the MVI. And so when we looked at the MVI and severe maternal morbidity, we didn't really find an association during the delivery hospitalization, but the association appears during the postpartum period. And so over here, you have the MVI divided by quartile. So you find an association in the third quartile and then the fourth quartile. These are the moms that are living in the highest MVI, maternal vulnerability zip codes. And so, again, showing the importance of the sort of the social risk factors that tend to show up once a mom loses contact with the healthcare system. That's where the vulnerability appears in terms of these social risk factors. Oh, sure. Access to healthcare. Right. Right. Yes. Yes. And it can be a lot of reasons why. I mean, healthcare access is one of them, not trusting the healthcare system. So they might have access, but they're not trusting to go back. So there might be a lot of reasons for that. Lack of insurance that I'm going to talk about now. Yes, all of these things. So these are some of the other clinical factors that we examined. So we looked at sickle cell disease. That's fairly common here in the Middle East. And we found that sickle cell disease accounted for 14% of the Black-white disparity in severe maternal morbidity during the delivery hospitalization. And this differs by state. So in states where there are more Black individuals, the percentage of disparity explained by sickle cell disease is higher than in states that have lower Black rates of Black individuals. Others include sickle cell trait, stillbirth, moms who deliver stillborn baby, iron deficiency anemia, and preterm birth. And I will focus a bit more about preterm birth. So what we found here is that moms who deliver preterm, they're at higher risk for severe maternal morbidity and for postpartum readmission. And so what you have over here is the gestational age at birth in weeks. That's on the x-axis. And then you have the rate per 10,000 deliveries. And so for moms who deliver less than or equal to 31 weeks gestation, they have their 12.6. They have a higher rate of 12.6 compared to those who deliver at 39 to 40 weeks. Similarly, for those at 32 who deliver 32 to 33 weeks, they're also at higher risk of having a severe maternal morbidity than those who deliver at full term at 39 to 40 weeks. And the story is similar in the postpartum period, 4 times and almost 4 times for 32 to 33 week deliveries. They're also at higher risk of readmission. And so again, almost 3 times if they deliver less than or equal to 31 weeks, and 2 times if they deliver 32 to 33 weeks. So all of that is what led to the ACOG, the American College of Obstetricians and Gynecologists, to develop a new paradigm for postpartum care. So traditionally, postpartum care has been, a mom delivers, she comes back and is seen around 6 weeks postpartum. But the ACOG now advises to have a blood pressure check, especially if they have high blood pressure, hypertension during pregnancy. And so they're advised to come back ideally within the first day postpartum. So they come back for a blood pressure check. If they're high risk, they're supposed to be seen within 1 to 3 weeks, be seen back by their obstetricians and care providers. And then the idea is to have contact with all women within the first 3 weeks, ongoing follow-up as needed. And then the hope is that these moms have a comprehensive postpartum visit and then transition to primary care so that they have regular contact with their care provider. But unfortunately, this is usually doesn't happen. And again, the barriers, some of these barriers have previously been mentioned: access to care, childcare, on top of taking a newborn home. Moms might have other babies they need to attend to, transportation, specifically those who reside in rural areas, and then work obligations. I see here a much better support system compared to the US, but in a lot of places, you see that moms have to go back to work at McDonald's or some of these fast food chains shortly after they give birth. And a lot of them do not have the support that we see here in places like Lebanon. So transitioning into a policy deep dive, I'm going to reflect on insurance coverage, again, being an important aspect for postpartum care, postpartum Medicaid extension, and abortion restrictions. So insurance coverage, as you all agree, is a critical element in order to gain access to care. And we have in the US what's known as Medicaid. Medicaid helps provide coverage for low-income individuals. So there's what's known as the Affordable Care Act, and that's the Obamacare. It provides coverage to adults with incomes up to 138% of the federal poverty level. And so that's in 2024, that's 21,000. So if you have an income less than 21,000, you're eligible to have continuous coverage, continuous insurance, if you reside in a state that expanded Medicaid. And so here you can see the states that have expanded Medicaid: Alaska, Arizona, Arkansas, California. A couple other states, mainly in the South, have not. So Alabama is 18% and 29% in Georgia, 26% in Florida. That's in a family of 3. If you're a single individual, it's, again, 21,000. A family of 3, it's 35,000. So if you're a single individual, you basically have no coverage in states that have not expanded Medicaid. And so Alabama, if you make 0 income, you don't have insurance. In places like in Florida and South Carolina and Georgia, if you have 0 income, you have no insurance coverage. And so once someone, this is the status of Medicaid expansion. You can see the majority of the southern states have not expanded Medicaid, and all the others here have expanded Medicaid. Now, all of these that have stars, they have trigger laws. A trigger law meaning that these states can decide to end their expansion status based on what's happening now. And so with the current administration, there's going to be big cuts for Medicaid in the billions. And so these states have the option to terminate their Medicaid expansion status if they don't receive federal funding. And so we'll see how these states are going to react. The money has to come out from someplace. And I don't know, what they're trying to implement now is work requirements. And so they're asking to get Medicaid coverage, they're asking people that they need to have at least, I think it was 40 hours a month in order to get coverage. If you don't meet the work requirements, then you basically will not have coverage. But there's a lot of issues with work requirements. It's not that, some people cannot work because they live in rural areas. Rural areas do not allow for the same opportunities of work. But there's also redetermination. So every 6 months, they have to redetermine that they're still working that amount, that number of hours, or doing community service or studying, whatever they qualify for. And some people, it's hard to do that redetermination every 6 months. So even though they might be eligible to do the redetermination and file for paperwork, and, especially if you're low income and don't know your way around things, you might lose your insurance because you don't know how. But also some other people might lose their insurance because they cannot work, they cannot find a job. Right. So for those with disabilities, yes, they can keep their insurance coverage. I think states are now starting to figure out a lot of these things because those have recently been passed. And so we'll have to see how states are going to react and where they're going to cut the funding from. They're excluded. Yes. Yes. Now, there are states that used to cover sort of non-citizens. So California was one of the more generous states. South Carolina, you only get coverage if you're pregnant. It's called emergency Medicaid. But all of that is probably going to be cut off too as well. So again, your income is an eligibility factor. Now, the other eligibility factor is pregnancy. And so in some of these states that I've mentioned before that have not expanded Medicaid, you can get insurance coverage if you get pregnant. And these are sort of the thresholds. States can have different sort of cutoffs. So California is more generous, 322% of the federal poverty level. Places like, I don't know, Kansas 171, Iowa, yes, it's 380% of the federal poverty level. It's 317. It's better than they improved it. It was lower. So based on all of that, again, if you get pregnant, you can get Medicaid coverage for your pregnancy. Now, there's a lot of sort of barriers to cross because filing for paperwork for South Carolina, for example, it takes around 3 to 4 months to get approval. So by the time you find out you're pregnant, you're 3 months, you're almost in your second trimester. You can still get care and sort of back pay, but a lot of people don't know that, and so they don't go get prenatal care because they're afraid of out-of-pocket spending. And so this is expected. It sort of shows that if you don't, for states that have not expanded Medicaid, there's more than 50% during pregnancy or postpartum who don't have insurance for new mothers with prenatal Medicaid coverage. So we're in this current grant that I have now, we're planning to look at the impact of Medicaid expansion. And we're trying to look at maternal mortality, severe maternal morbidity, but also to look at hospital quality. And the reason why we're looking at hospital quality is because a lot of uninsured people can go to the emergency department or can go get care. And so a hospital ends up being, in the negative margin if these people are not paying what they owe the hospital. But Medicaid expansion allowed these individuals who are not covered in order to provide, payment for their procedures or services. And so the fear now, again, with these new laws is that cannot pay for their services. So these hospitals are going to close in rural areas. Currently in the US, around 50% of rural counties do not have an obstetric unit to deliver moms, to deliver pregnant women. And this situation is going to be more exacerbated now with Medicaid, and they're not going to invest in improving quality and all of that. So we're hoping to look into that in the coming year. So beyond Medicaid expansion, there's also Medicaid extension. And so given the maternal health crisis, what they came up with a policy, the American Rescue Plan Act, to extend coverage from 60 days to 1 year postpartum. So now moms in all these states and all these sort of blue states here can get access to services beyond the traditional 60 days because they can get insurance coverage up to 1 year postpartum. There's still 2 states that haven't extended coverage. These are Wisconsin and Arkansas. And we recently just received another R1 in order to look at insurance coverage, extending postpartum Medicaid, and how that impacts sort of contraception, outpatient postpartum care, management and treatment of conditions, although we're not going to be observing that, but we're going to look at short interpregnancy interval, newborn outcomes and maternal outcomes, and healthcare use. And this is sort of, some of you might be familiar with the Anderson's behavioral model, health model. Basically, insurance coverage is an enabling factor. And so once you have coverage, you're less likely to have insurance disruption or transitioning to another type of insurance, which might affect your care continuity. And that would result in out-of-pocket medical care spending, so you're not going to utilize healthcare services. Okay, I'm going to transition now to abortion restrictions. So some of you might be familiar with some of this, but the abortion restrictions have really resulted in healthcare access issues. And so these are stories that were popping up in the news media on a regular basis. This is the story of a pregnant teenager who died after trying to get care in 3 visits in an emergency room in Texas. And this lady was already miscarrying at 20 weeks. So there was absolutely no way for that fetus to make it. But they were trying ultrasound after an ultrasound to make sure that the baby had no heartbeat in order to provide with an abortion, to provide her with an abortion. So this lady passed away. This is another lady also. She was also miscarrying in another Texas hospital. And in Oklahoma, a woman has been told in order to wait in her car until she's crashing in order to get abortion care. And also this person had a molar pregnancy. So again, no reason in order to deny care for this patient. But unfortunately, states that have passed these abortion restrictions are doing very little in order to study their effects. And so I mentioned earlier the maternal mortality review committees. Georgia dismissed their maternal mortality review committee. One of the news media outlets obtained information about 2 deaths that happened in Georgia, knowing that those 2 deaths were due to denying abortion care. And these mortality review committees are supposed to be confidential. And so Georgia dismissed all the members of the review committee because they said those details were leaked. Texas did the same. They skipped 2 years of maternal deaths that happened when these abortion policies were enacted. Their reasoning was to catch up, because they're usually 2 years behind, to catch up on more recent deaths. So this is the status of abortion bans currently. There's 12 states that have completely banned abortions. South Carolina, bans abortions at 6 weeks. That's long before a lot of moms know that they're pregnant. The fatal fetal anomaly exception, 10 states have no fatal fetal anomaly. So basically, if you have a baby you know is not going to survive, you still have to carry that baby to delivery. So health exception, also 6 states, if the health of the pregnant woman is at risk, 6 states are not allowed to provide abortion. Rape, incest exception, 8 states have no exception. And this is a recent paper that was published showing abortion bans to be associated with infant mortality. And so what they found was that mainly Black moms were more likely had a higher mortality than expected for their infants. And when they looked at it by cause of death, it was mainly due to congenital anomalies. There was still an association with non-congenital, but a bigger change for the congenital anomalies. So we're looking at this as well, and we're trying to look at maternal mortality. We have a paper under review now on that, on birth outcomes and infant mortality and disparities within these outcomes. Okay, so the last point I'm going to talk about is designing interventions. And so we know that hypertension, especially postpartum hypertension, is a major cause of maternal mortality and severe maternal morbidity. And so what we're doing is we're implementing telehealth. And so basically the moms get blood pressure cuffs. These cuffs transmit readings to the mom's electronic health records, so healthcare providers can have near real-time access to their blood pressure readings. And based on that, the nurse reaches out to the patient and tells them whether they need to change medications or to increase their dosage, or to come back and be seen. We're doing that at a hospital in Colombia, and it's a hospital that has high-risk patient population. More than 70% are on Medicaid. We're looking mainly as outcomes on blood pressure ascertainment, but we're also looking at readmissions and ED use in the postpartum period. And the last project I'm going to talk about is NEST, Neonatal Excellence in Supporting Transitions. This is a project we're just starting to work on for the protocol. But basically, I presented earlier data on how moms who deliver preterm babies are at very high risk for severe maternal morbidity. So we're trying to, again, these moms don't get the postpartum care that they are required to get because they have to be with their babies in the neonatal intensive care unit. So we're trying to see how does the integration of doulas and midwives in the neonatal intensive care unit for moms who deliver less than 34 weeks impact their healthcare utilization and outcomes. And we're doing a randomized trial with a postpartum care usual study, a doula. And we'll do all of the mental health screening and look at some of these outcomes. Basically, the doulas will meet with the mother in the NICU at least once a week, and then we'll coordinate any needed community services. Doula is like a day, how do you say? Day. So doulas, they're trained to, how does it differ? Midwife would take care mainly of your medical needs. Doulas is more of your community needs. So you need access to transportation, you need support, you need diapers. They would refer you to all these community services. And they're amazing individuals because they get really close to the moms. And so there was a story of a mom who was going to commit suicide, and that doula knew that mom and was able to get to her in time to sort of, so they're, their support, basically. And I guess that's mainly it. Just want to thank you all for listening. I had an acknowledgement slide. I don't know where it went, but I acknowledge all the team that I work with.
Thank you so much, Nancy. That was really interesting also to see what happens in the US. Maybe we're not very familiar with all of these disparities and poor health outcomes, even in the most developed countries. Now خلاص with this leadership. Okay. All right. So we're going to open up for discussion, and we're going to be also monitoring the chat. If anyone also from our online audience have questions, please just jot it down in the chat. Yes, Monique and then Sausan. We're going to ask the question here and then give.
Okay, so thank you. That was really interesting, very captivating, and congratulations on all the work. I'd like to ask you about the guidelines of the ACOG. Is it based on those evidence? To what extent is this based on the evidence? Because now, like, we talk about the postpartum period differently. Yani, hatta even people have different definition of what is a postpartum period. So to what extent the guidelines actually are evidence-based guidelines, and to what extent people actually follow those guidelines? Because if they are really based on your data or researcher data, we should be seeing at least some changes. So are you monitoring?
So the ACOG published these guidelines in 2018. And yes, it is based on evidence that there are adverse outcomes happening, especially high-risk moms. Are they happening is a different story. I think the rates of postpartum visit vary. There's been a push to sort of reimburse healthcare systems if there are postpartum visits. The more, the better. But are they happening? I don't know. Well, there is a lot of debate about it. Again, traditionally, it's been the 6 weeks postpartum, but there's more and more evidence coming out that we should go beyond the 6 weeks, and that's not enough, up to at least 1 year postpartum. So there is a push for that, and that's why they extended insurance coverage up to 1 year in order to facilitate healthcare access. So we will be looking at that based on, now that these moms will have insurance coverage, and see whether that has changed their outpatient postpartum care. So they advocate for transitioning to primary care beyond that. Again, not to have it more of a process rather than a one-time visit. So they do advocate for continuous care beyond the 14-week postpartum.
I think I had a question about this as well, but I can't figure out. I think you mentioned that the majority of postpartum mortality happens up to 66 days postpartum. I think I remember, or maybe I'm mistaken. 60 postpartum. Okay, never mind. I'm sorry, but I wanted to ask you, because now the language is racism, not race. It's not about race as a biological factor, but it's about racism. And I was wondering if the studies or the data that you showed can be looked at a smaller scale than the states, in terms of areas that are more segregated than other areas. If there's data on this, and which may also inform the recommendations that you would make.
We can look at segregated areas. It was a topic I was interested in at some point, and then I got busy with other stuff. We haven't looked, but there are some papers out there that, yes, show that segregated areas are more likely to have more adverse outcomes than non-segregated areas. There's also some evidence about the use of hospitals. Hospital quality, that's something we're looking at, is an important indicator for outcomes, especially during the delivery hospitalization. And there's some research showing that Black women who live in segregated areas are more likely to go to lower quality hospitals than those who don't live in segregated areas. So it's a very important indicator, specifically in the South. And yes, there is, we're hoping to look at that in the future.
So Dr. Kabakian says that, thank you, Nancy. She's interested in knowing how much consideration is being given to the evidence from the US pointing to systemic discrimination based on race and gender happening during labor and birth in US hospitals. There is evidence that this is also driving the increase in morbidity and mortality rates. When not addressed, the effect of other interventions will remain limited.
Yeah, I mean, this is very important. We currently have one of the team members I'm working with on the NEST study, neonatal excellence support, the doula, the midwife doula study. She got grant funding in order to have a doula on the labor and delivery unit. And basically that doula would attend each delivery to advocate for these women, in terms of, when someone says they need a cesarean section, can we do more in order to have her deliver vaginally rather than have a cesarean delivery? So definitely a very important topic. And there is an attempt to address it more and more, but I don't know how sort of you know, it's not easy to look at it with currently existing secondary data. So more prospective studies for that.
Thank you, Nancy. This was, again, very interesting. So I have two questions. One, you mentioned, you said it's a maternal health crisis in the US. So is this your definition or description of the situation, or this is a national policy? And will this reflect in, because what you've shown is contrary to, if it is a crisis, it's not reflected actually in what the states are doing and what the federal government is doing. So I'm happy that you got your grant, but my question whether you're concerned about even funding towards research in that line. My second question is, I've read an article once. Actually, it was in the National Geographic, but it's but they were talking about the maternal death among for a Black woman who comes from a high economic status. So, and the article says that a white family compared to a Black family, adjusting for everything, that they are the same high quality, both university graduates working in banks, good income, and still she died in the hospital. Part of it, what Tamar mentioned, that she was not given the proper care. But again, they raised the issue of the intergenerational violence, that they've been discriminated against, slavery, discrimination, apartheid, whatever, for hundreds of years, that could have impacted now even the genetic makeup there. So is that something that can be picked up in your research?
Yeah, thank you, Dr. Nwahid. So it's epigenetics, and there is, you know, studies that are starting to look into that. It's not something that we can look at. We don't have, this is all secondary data. We're not collecting any biological samples in order to try to look at that, but definitely there is a lot of research sort of starting to talk about racism and how that might have impacted their epigenome and their adverse outcomes in terms of developing, you know, they have Black individuals, Black moms have higher rates of preeclampsia, of a lot of other things. So not at this stage, I guess. We're not collecting any samples. Yeah, thinking about it, it's an involved study in terms of like what samples at what time points you need to collect. Regarding the first question, trying to remember what was the crisis. Yeah, the maternal health crisis. I mean, that's how it's labeled. I mean, again, the US, given the, you know, it's a wealthy country, but it still lags behind all of the other high income countries. And the Medicaid extension in terms of providing insurance coverage was one thing that came out of it in terms of, you know, these moms need to be provided more access because moms are dying in the postpartum period. And given the status of the US, it's kind of unacceptable having these rates compared to other high income countries. So yes, it's been in the, you know, in the press that there is a maternal health crisis. It might become worse with the abortion restrictions as well now, and just trying to look at that. Yes, the losses of funding is definitely going to have an impact. I just don't know how at this stage. I mean, how that's going to impact hospital quality, hospital closures, especially in rural areas. I mean, again, 50% of rural counties do not have a hospital or an OB to deliver moms. And so moms have to commute more than 1 hour in order to get care. So all of that might get exacerbated with what's happening recently.
Nancy, thank you so much. But we have 1 more minute, and I would like if you can just answer in a minute very quickly our online audience. So we have a question by Federico asking about, you said that 15% of deaths are recorded as mental health death, depression, suicide. Were these cases recorded if the woman had no previous history of mental health issues?
Well, I don't know the details of how they're recorded, but basically the maternal mortality review committees decide on the cause of death for a specific case. They don't really provide much more details beyond that. So I don't know if they've had a previous history beyond that. You have as much information as I do, but at this stage, PRAMS is not currently active. I think at some point, and I don't know if it is still, but these websites were taken down. And so a lot of people I know went and just downloaded the data ahead of time, just in case, but I don't think PRAMS is active at this stage.
Thank you so much, and thank you everyone for your engagement. I'm sorry, but there's a class and time is over. If anyone wants, they can reach out to Nancy afterwards. Thank you so much, Nancy. That was fantastic.